Holio-Palmaz creates the vascular stent. And in 1990, Getz Richter from Germany published the first tips in humans, 1990. And these are his images from the first human tips that he published. So we have to take all this wealth of knowledge for treating portal hypertension with us when we attend multidisciplinary conferences. And I know for the teams in Tanzania, every time I speak to them, I tell them the importance of showing up at these multidisciplinary conferences to let the other physicians in your hospital know what interventional radiology is capable of providing for their patients. So in this case, everyone in this conference room is looking at this image of a patient with really pretty advanced cirrhosis and portal hypertension. And at a conference like this, we pull out our IR toolbox and we tell our colleagues what we're capable of doing for their patient in interventional radiology. In order to discuss portal hypertension with your colleagues who are experts in portal hypertension, you have to talk their language, and you have to be familiar with the three types of portal hypertension: sinusoidal portal hypertension, pre-sinusoidal portal hypertension, and post-sinusoidal portal hypertension. I'm going to briefly discuss these three types. When you consider the patient with portal venous hypertension, you have to know normal anatomy first. So this is an illustration that shows a really normal non-cirrhotic liver and portal veins going to the liver that were wide open, and the hepatic venous system draining the liver. Those veins are also wide open. In order to determine what type of portal hypertension a patient has, you have to get portal venous pressures and central venous pressures. Now, getting into the portal vein is an invasive procedure with risks. So decades ago, this technique was developed where you enter the right internal jugular vein with a catheter and send a catheter down to the middle hepatic vein. And this catheter has a little balloon on it, and you inflate the balloon to wedge that hepatic vein, and then you get pressures beyond that balloon, okay? So here's an example where a balloon was inflated, contrast was injected, and this contrast is going through the sinusoids, and you see the portal system here starting to fill with contrast. The way this happens is your catheter is in the central venous system here, and when you inject contrast, you are sending that contrast across the sinusoids into the portal system. When you have this tip of your catheter in the central veins open to your transducer, your pressure transducer, the portal system pressures are transmitted through the sinusoids to your catheter in the hepatic vein. And that's an easy way to find out what the portal venous pressures are within about 1 millimeter or so. And it saves you from the risky procedure of having to get into the portal venous system directly to measure those pressures. So sinusoidal portal hypertension is described as increased vascular resistance due to dysregulation of the hepatic sinusoidal endothelial cells and the hepatic stellate cells. So here's an illustration of what's going on here. The hepatic veins are wide open, portal veins are wide open, unless it's very late in the disease when they start becoming thrombosed. And the patient has fibrotic changes all throughout the parenchyma of the liver. This is a patient with sinusoidal portal hypertension. And these are the patients we do TIPS on. Almost all of our patients that we intervene on for portal hypertension have this pathology, sinusoidal portal hypertension. But you have to be aware of pre-sinusoidal portal hypertension also, and I'm going to show you what examples of that. So in pre-sinusoidal portal hypertension, in the setting of schistosomiasis, which is the most common type of pre-sinusoidal portal hypertension around the world, what happens here is a schistosomal oocytes find their way into the very distal branches of the portal system. these eggs land in those little branches of the portal system and cause fibrotic changes there, and that causes the portal pressures to be elevated. If the patient has a central portal venous occlusion, as you can see here, the intrahepatic portal veins are wide open and the hepatic veins are wide open, but there's a central occlusion here, whether it's pancreatic cancer or some other type of central mass pressing on the portal system, that causes the patient to have the sequelae of portal hypertension, even though their liver is non-cirrhotic. Probably the worst case of pre-sinusoidal portal hypertension to deal with as a radiologist is this case where you have extensive thrombosis through the entire portal system. The superior mesenteric vein, inferior mesenteric vein, and splenic vein are all occluded with thrombus, either fresh or chronic. And there's the case of isolated splenic vein thrombosis, like you see here, where the other components of the portal venous system are wide open. Main portal vein, SMV, IMV are wide open, but the patient's splenic vein is occluded. This is called sinusoidal hypertension or left-sided portal hypertension. And of course, a very rare type of pre-sinusoidal portal hypertension I have illustrated here, where a patient may have had trauma in the past, or they've had a pancreatic biopsy or liver biopsy, and now there's a communication between the arterial system and the portal system, and that shunting of arterial blood into the portal venous system causes the portal pressures to become elevated. Now the patient develops symptoms of portal hypertension. Even though their liver is totally non-cirrhotic, they're presenting with portal hypertension because of this fistulous communication with the neighboring artery. Post-sinusoidal portal hypertension. Let's talk about this for a couple of minutes. In the setting of veno-occlusive disease, there are microscopic occlusions at the level of the very tiny little hepatic venules in the liver. And this causes the portal pressures to build up inside the portal venous system. This might be a patient who's been on chemotherapy or a patient with constrictive pericarditis, where they get these microscopic occlusions inside their hepatic venules. If you have a central mass obstructing outflow of the hepatic venous system, or if you have an IVC web or an hepatic vein web in this area, that obstructs venous outflow, and that patient will have portal venous hypertension. If the entire hepatic venous system becomes thrombosed, and this goes on for weeks and months and becomes a chronic process, such as patients who are on oral contraceptives, or they're hypercoagulable from cancer or from polycythemia vera, those patients will have portal hypertension because of hepatic venous outflow occlusion. And of course, if you have a patient with post-sinusoidal portal hypertension due to heart failure, their hepatic veins are wide open, their portal veins are wide open. They may have developed secondary cirrhosis from their heart failure, but this is another patient with post-sinusoidal portal hypertension. And of course, any patients with portal hypertension are at risk of developing ascites. Ascites is a big problem. These patients often lose weight. The reason they're losing weight is because they have muscle mass. They're in a catabolic state. Their body's trying to keep body temperature for not only their lean body mass, but also all of this fluid in the peritoneal cavity. They're trying to keep at body temperature, and that's a big energy loss for them. Those patients may develop umbilical hernias. They may get incarceration of bowel inside the umbilical hernia. They can develop inguinal hernias. They have mobility problems. It's hard to get around with a belly full of ascites. These ascites can become infected. And also, it's just a body image issue with these patients. They don't like looking like they're 6 or 8 months pregnant when they're walking around in public. The other complication portal venous hypertension patients can have is variceal bleeding, When you look at a normal esophagus on the left, it's quite different from a patient with esophageal varices you see on the right side of this image. These varices can pop, and the patient can have catastrophic bleeding. If the patient is seen electively by the endoscopist can get these varices and place bands around those varices to keep them from bleeding. There's a limit to how many times an endoscopist can do this, but here's an example on the right side of the screen where the band was placed around this varix to prevent it from bleeding for this patient. And of course, if the endoscopist does this too many times in the esophagus, the patient can develop esophageal stricturing because of all this banding that the endoscopist performed for that patient's esophagus. Now, when you go to the multidisciplinary conference and discuss patients with portal hypertension, most often your other colleagues are patients who deal with liver patients every day, whether they're hepatologists or liver surgeons. But now and then, your colleagues that show up might be from OBGYN, okay? And here's a very nice example of a patient who is 32 weeks pregnant, and she has very advanced cirrhosis. And on the left side of the screen, you can see the recanalized umbilical vein draped over the uterus, and you can see the fetus inside of this uterus. And in this case, the obstetricians want to perform a C-section. They know they're going to have catastrophic bleeding through this C-section, and they want you as a radiologist to help them get this patient through the delivery of this baby without any complications. And they look to us to help them because they know we're experts, okay? One of the past presidents of the SIR is Brian Stankin, and he is quoted as saying, "We are experts at delivering care in a virtual reality environment." And that's what we're experts, okay? All of you looking at this PowerPoint, you are experts in radiology, in diagnostic imaging, and interventional radiology. And your colleagues really depend on you, okay? So in these conferences, we look at the imaging, we debate what the best care is for this patient, and if it's decided that the patient goes to interventional radiology, we tell our colleagues what the plan is, okay? We open up our toolbox and tell them exactly what we expect to do for their patient. So what we're going to do now is talk about a simple, standard, uncomplicated TIPS procedure for sinusoidal portal hypertension that has been around since 1989 and is widely practiced around the world, and has really replaced surgical treatment for these patients. It's very rare now for a surgeon to put a shunt in for a patient with portal hypertension. All right, so this is a simple case of a patient with sinusoidal portal hypertension, advanced cirrhosis, a lot of varices around the stomach and the distal esophagus. For this patient, we're going to take them to the IR suite, and we're going to place a 10 French sheath in the right internal jugular vein. We're going to send that sheath down into the inferior vena cava, and we're going to use this long TIPS needle, which is curved, and we're going to send that into the hepatic venous system, okay? So this is a really long cannula. Our needle is at the end of the cannula, and we are going to place this in the middle hepatic vein for the patient. Once the tip of this cannula is about 2 centimeters from the inferior vena cava, we're going to start rotating this cannula, and we're going to rotate it counterclockwise so the cannula points anteriorly through the anterior wall of the middle hepatic vein. And then we're going to send it inferiorly and anteriorly. We're going to put it into the area where we think the portal vein is, and then we're going to start aspirating. We're going to aspirate looking for free flow of blood into our needle. If we get free flow of blood, we probably are in the portal venous system. We're going to inject contrast and see if we're in the portal system. And if we are, we're going to send a wire down into the main portal vein. And it's easy from there. We just simply dilate the tract with our balloon angioplasty catheter. We're going to choose a stent. At our hospital, we use the Viator stent for TIPS procedures, and we're going to let that self-expanding stent expand in the tract and then take it up to 8, 9, or 10 millimeters in diameter for this patient. And here's the end result, a really nice look at a covered stent, a Viator stent, placed between the middle hepatic vein through liver tissue into the right portal vein for this patient. And what we're looking for to confirm that we're actually done with our procedure is we're looking for a pressure gradient between the portal system and the hepatic venous system of 12 millimeters of mercury or less. So, that's the easiest scenario that I just showed you. That's when everything's going great. And, I can tell you at our hospital, our first TIPS that we ever did took 13 hours. I can tell you now that we're well practiced with TIPS procedures. A typical TIPS for us takes about 45 minutes to perform. Sometimes when you're trying over 30 minutes, 45 minutes to get your needle into the portal vein, you simply cannot get there. This is usually the setting where the portal vein is too anterior with respect to the hepatic vein, and you just cannot connect those two veins. So I'm going to tell you a couple examples of things that can help you get a successful TIPS when you're starting to struggle. One thing you can do is opacify the portal venous system by using wedged hepatic venography. I'm going to show you of that. Another thing is you can place a target in the portal vein using ultrasound guidance, whether that's a wire or a little snare in the portal vein to show you where exactly the portal vein is so you can aim your needle at it. You can also use the Gunsight approach that was described in 1996 by Ziv Haskell. And you can also use the ICE intravascular ultrasound catheter. That's an expensive device, but it really does save you time doing these TIPS procedures. So with hepatic wedged portal venography, what you're going to do is send a catheter, a balloon occlusion catheter, into the hepatic vein, inflate the balloon, and inject contrast, whether it's iodinated contrast or CO2 contrast, into the hepatic vein. That contrast passes through the sinusoids and into the portal system, and you can visualize the portal system quite nicely. So here's an example. On the left side of the screen, there is a balloon occlusion catheter placed inside the hepatic vein. It's wedged, it's inflated, contrast, in this case CO2 is injected, and that CO2 fills the portal system quite nicely. And now you can see where the main right portal vein is, and in the image on the right, they successfully pass their TIPS needle into the right portal vein using this CO2 portal venography as a guide. Then there's the Gunsight approach. This is a technique I've used many times, and this was first described, like I said, in 1996 by Haskell and his colleagues. What you do is use ultrasound and find the portal venous system, get your needle into the portal venous system, and send a catheter into the portal vein. You're going to place a snare through that catheter in the portal venous system. You're going to have another snare in the hepatic vein, okay? And you're trying to connect these two structures, the hepatic vein and the portal vein. So now you have a snare in those two structures. And your job at this point is to pass a needle, a transabdominal needle, through those two snares. If you can get the needle through those two snares, you know that you have connected those two venous structures, and now you can snare your wire through the neck and use that wire as a rail to perform your TIPS procedure. When you have those two snares in the portal vein and the hepatic vein, what you're going to do is you're going to rotate your image intensifier in all different obliquities, in RAO, LAO, AP, craniocaudal, caudocranial, and your goal is to line up, to superimpose those two snares one on another. And I'm showing you here the Gunsight analogy that Ziv Haskell was referring to. In this case, on the left side of your screen, you're seeing these two gun sights. They're not superimposed on each other yet, but when they are superimposed on each other, you can see you're looking right through both gun sights, okay? They're perfectly lined up. And what we're gonna do in IR is line up our two snares with obliquities of the tower so that you can line up and pass a needle from one snare to the other snare, okay? So there's our two snares. You want to get them closer together, and you're going to look at different obliquities, trying to make those two snares overlap each other, all right? And in Ziv Haskell's publication from 1996, he shows you this picture here where they're looking on the AP projection. Here's the snare in the portal vein. Here's the snare in the hepatic vein. And this particular patient already had a TIPS procedure, but Haskell wanted to create a parallel TIPS for this patient, and he used this Gunsight approach. When he obliqued the tower, all of a sudden, these two snares are superimposed on each other. Here's the hepatic vein hepatic vein snare. The smaller snare is in the portal venous system. Now those two snares are lined up very nicely, and he's going to pass a needle from one snare into the other. Here is the needle going through the portal vein snare, and it's the hepatic vein snare. And now he's going to put an exchange length guide wire from one vein into the other, snare it, and pull it through the neck. And now he's got a wire going from the neck through the IJ vein, into the hepatic vein, into the portal vein, out through the abdominal wall. And he has very nice through and through guide wire access. And now the rest of the case is easy through several steps to get everything lined up for a portal vein access. And here he started off with this one TIPS shunt for this patient. And now he placed his parallel stent, this parallel TIPS shunt for this patient using the Gunsight approach. And now there are two TIPS, two parallel TIPS in this particular patient. A really nice technique to use for many of your cases. Another instrument that's nice to use is the ICE catheter, or the intracardiac echocardiography side viewing intravascular ultrasound catheter. It's a lot of words, but this is a great instrument. We use it at our hospital for all of our TIPS procedures. It really does save time. There are a couple of these on the market. This is the AccuNav intracardiac ICE catheter. And this catheter is placed into the inferior vena cava. The ultrasound transducer is right here at the tip of this catheter. And you can pass it either through the neck or through the femoral vein. Here's the transducer in the catheter. Here is the TIPS needle. And in this publication from 2008, they are showing the TIPS needle being passed into the portal venous system using this side viewing ultrasound in the inferior vena cava. Let's talk about post-sinusoidal portal venous hypertension, or Budd-Chiari syndrome. All right, we already discussed the plain and simple, normal, run-of-the-mill TIPS procedure we do commonly all around the world for patients with cirrhotic sinusoidal portal hypertension. Let's talk about other variants of portal venous hypertension. We're going to start talking about post-sinusoidal portal venous hypertension, or Budd-Chiari syndrome, and how we treat those patients. This CT scan shows you the classic nutmeg appearance of a patient with congestion in their liver because of Budd-Chiari syndrome, hepatic venous outflow obstruction. In this case, the patient's hepatic veins are open, but they're centrally occluded. Okay, there's flow inside the hepatic vein. This is the easiest type of Budd-Chiari syndrome to treat, because if you can just get rid of this web in the hepatic vein or the IVC, you will restore venous outflow from the liver and reduce the patient's portal hypertension. So in this case, the patient was accessed transhepatically you can see the contrast going through the intercostal space into the hepatic vein. Contrast is injected. Early in that contrast injection, you can see the hepatic vein fill. Late, okay, after seconds, you can see that contrast trying to get out of the liver back to the heart, and it has chosen the diaphragmatic veins, which you see filling with contrast here, as a way for the blood to get back to the heart. So your job as an interventional radiologist is to put a balloon in here and break through this occlusion to restore hepatic venous outflow for this obstruction for this patient. So here's a nice example where a large balloon, a 12-millimeter diameter balloon, was used to break through that obstruction in the hepatic venous system. And this is a pre and post picture where before the balloon angioplasty, you see all these collaterals in the diaphragm. After angioplasty, you're no longer seeing the collaterals, and contrast is able to get out of the liver and back to the heart quite easily. The more difficult patient to treat is a patient with Budd-Chiari syndrome and chronic hepatic vein occlusion with chronic thrombosis. For these patients, you're going to do what's called the DIPS procedure, a direct intrahepatic portosystemic shunt. In this description from 2008, on CT, they saw the portal vein, they saw the inferior vena cava, the hepatic veins are occluded, and they are going to go across this bridge of liver tissue from the IVC into the portal system using ultrasound guidance. They're going to use that ICE catheter that I talked to you about a minute ago, and they are going to use this ICE catheter to pass from the inferior vena cava, through the wall of the inferior vena cava, through this liver tissue, and into the right portal vein. At the completion of the procedure, they have made this passage into the portal system through the wall of the inferior vena cava. They dilated the tract up and put a Viator stent in to communicate between the portal vein and the IVC. A nice procedure to perform for a patient with totally occluded intrahepatic veins. Let's talk about other cases of pre-sinusoidal portal venous hypertension. In this case, the patient's intrahepatic and extrahepatic portal vein is totally occluded, okay? You cannot do a standard portal, you can't do a standard TIPS in this patient because the portal vein is chronically occluded. So what are you going to do? You're going to get a wire catheter access into the splenic vein, and you're going to get a wire into the splenic vein using ultrasound guidance. You're going to pass this needle into the splenic vein, get in there with a catheter, and try to find your way across that chronic occluded portal venous system. And here's what was shown in this article from 2016. They found their way across the chronically occluded portal vein with a catheter and guide wire, and then they put a snare in the occluded portal venous system so that going from the internal jugular vein to the neck, they pass their tip set through the hepatic vein into this snare, and then through a series of steps, they snare an exchange length guide wire from their tip set in the portal system, and through a series of steps, they drag that wire out through the spleen, out through the skin, and now they have through and through guide wire access from the IJ vein through the spleen and outside of the skin. And at this point, it's an easy procedure. Now they just dilate the tract, they put their tip stent in there. In this case, they had to extend their stent with another stent through that occluded portal vein. And in that way, they were able to decompress the portal system for the patient. Let's talk about sinistral portal venous hypertension or left-sided portal hypertension. This is a patient where the entire portal system is opened, but the splenic vein is occluded. Okay, this was a 70-year-old man. He had a 30-unit variceal bleed. He's non-cirrhotic, and he has a history of pancreatitis with occlusion of his splenic vein only. So what we're going to do for that patient is get into his portal system through the liver and try to get our catheter from the wide open portal vein through the splenic vein that is occluded. And I have a little illustration here that shows the spleen, that shows his patent portal system. This is where we should be seeing the splenic vein, but as you can see here, it's completely occluded. And our job now is to get across this occluded splenic vein with a glide wire and a catheter and get up to the splenic hilum here. So that's what we did. We got across this occlusion through the splenic vein for the splenic vein hilum and into the portal system. And I just put an overlay of what the stomach looks like here. Patient, as you know, with splenic vein occlusion, they have these big gastric varices. This blood is trying to get to the normal pressure portal venous system, and it does so through the wall of the stomach and through the coronary vein. So we plan for this case to put a stent, a covered stent. In our case, we used a Viator stent. We want to put the stent in that occluded splenic vein to restore blood flow from the spleen into the normal pressure portal system. We balloon dilate the splenic vein. We use a covered stent in the splenic vein. And then we line this occluded splenic vein with our covered stent. And here's our end result, where we inject contrast into the splenic hilum, and contrast goes from the splenic hilum venous system through our stent and into this portal system for this patient who is non-cirrhotic and has normal central venous portal pressure. A pre and post picture before stent placement and post stent placement for this patient with splenic vein occlusion. A really nice case. More recently in the literature has been described the PRES procedure. And what this stands for is percutaneous retroperitoneal splenorenal shunt. Our colleagues in Australia first described 2 cases of the PRES procedure a couple of years ago. We have since performed 2 of these cases at our hospital in North Carolina. One of our cases is shown here, a 50-year-old man with myeloproliferative disorder, portal hypertension, chronic occlusion of the portal venous system, splenic vein, and superior mesenteric vein. This patient was banded several times, 14 times, and then came to our attention to see if we can do something for him. So I'm showing you on the left side of the screen a patient with normal portal venous system, wide open portal vein, mesenteric vein, splenic vein. Our patient on the right side of the screen had complete obliteration of his portal system and most of the splenic vein, as you can see here. I challenge anybody to find any normal part on the right side of the screen of the portal venous system. It's just all gone. It's completely occluded. When you measure pressures, in a normal patient on the left side of the screen, a normal pressure would be a portal venous pressure of 8 and a right atrial pressure of 6. Our patient had a splenic vein pressure of 23 and a right atrial pressure of 6 millimeters mercury with a 17 millimeter mercury pressure gradient. This patient had extensive esophageal varices. On endoscopy, we have these giant esophageal varices that you can see here. We offer this patient a percutaneous splenorenal shunt. Here's how we did it. On CT, we were able to see in the splenic hilum, luckily, a little bit of the splenic vein was still patent. You can see it here. On CT, you can see really nicely what's left of the splenic vein, and you can see that the patient's left renal vein is wide open, and these 2 structures are literally millimeters apart, and we want to connect these 2 so the splenic vein blood flow can travel into the renal flow, to the IVC, and back to the heart. So we go transfemorally and put a catheter in the left renal vein. We go through the spleen and place a catheter in the splenic vein. We can see these two catheters side by side, splenic vein, renal vein. And our next job is to pass a catheter from the splenic vein into the renal vein, and then snare a wire and pull that through the femoral vein and place a stent and put a splenorenal shunt in there for this patient. What we use for this patient is a device called the radiofrequency power wire. This wire is activated. It becomes very hot when we deliver energy to the tip of this wire. And this wire literally goes through tissue like butter when we activate it. And in this case, we're going to puncture through the splenic vein wall into the renal vein and send this wire from one vein into the other, and then send the catheter over the wire, and then put a exchange length guide wire from the splenic vein through the femoral vein. And now again, we have this through and through wire access that we can work with to place our splenorenal shunt. We balloon dilate the tract from the splenic vein to the renal vein. We put a stent in, a nice flexible covered stent. And there you can see this covered stent on this image here fluoroscopically. We inject contrast at the end of the procedure. Contrast goes from the splenic vein through this shunt into the renal vein and into the inferior vena cava. A really nice result for this patient. And on CT scan, you can see the communication from the splenic vein into the renal vein with this stent. Before our shunt was placed, there was a 17 millimeter gradient. After the shunt was placed, the gradient was greatly reduced for this patient, and he has not had any bleeding since we did this procedure 2 years ago for this patient. How do you follow up this patient? You don't want to keep doing a CT for this patient. If you do an ultrasound, you're blocked by bowel gas from seeing this stent from an anterior approach. For this patient, you're going to use the spleen as a window for your ultrasound, and you're going to visualize this splenorenal shunt through the spleen using ultrasound guided ultrasound for this patient. It's a difficult follow-up ultrasound to do, and you really have to have a good technologist to see through the spleen to measure Doppler velocities in our shunt to make sure it's still functioning well. Let's talk about TIPS complications. As you know, I told you earlier on that our first TIPS took 13 hours. For someone who's inexperienced at placing TIPS, the TIPS procedure can take a long time. It can take hours, okay? If you're not careful, you can cause radiation skin burns for these patients. Here's a case that was described 2019. 10 days after the procedure, the patient was complaining of itching on their posterior wall of their abdomen. 3 weeks later, the patient was developing erythematous papules in the skin. 4 weeks later, these papules are becoming more prominent, and already you can barely see this rectangle of erythema for this patient, okay? Normally, rashes have a geographic border. This rash has a definite rectangular border, and you know that this is where your radiation was coming into the patient's body from your radiation source during the procedure. 6 weeks later, the patient has wet desquamation in this area of their skin where the radiation was entering their body during the TIPS. At this point, the radiologist asked the dermatologist for help. They started applying wet to dry compresses for this patient, which was done for several weeks. And 2 weeks later, the skin is looking better. 12 weeks later, the skin is starting to heal better. At 16 weeks, it's looking even better. And at 28 weeks follow-up after their TIPS procedure, here is pretty much the final result that the patient was left with. So these long procedures can expose the patient to high radiation doses. You want to try to spread that dose out over their skin by using different obliquities during the procedure. You want to always also follow these other rules of ways to minimize radiation for this patient during the tips. You want to raise the table high as you can get it, spread the skin dose out, use pulse fluoroscopy, use last image hold, last fluoroscopy hold, minimize magnification, reduce your angiography frame rates per second, and collimate. Those are all ways to reduce radiation dose for the patient. Another complication of TIPS is in a pseudoaneurysm in the hepatic arterial distribution. Here's an example of a pseudoaneurysm in the liver. You're going to use your coils for this patient. You're going to coil off that pseudoaneurysm by getting access into the femoral arterial system, send your catheter up to the liver. You're going to identify the hole in the side of the artery. You're going to pass that hole and start placing coils. You're going to bridge this damaged area of the artery with coils as you retract your catheter, and you're literally going to lace that damaged area of the artery with these coils and just wall off the injury for that artery. Another complication is, even though you placed your tips successfully, the patient still has portal hypertension. And for a patient like this, you're going to place a parallel tips, as is shown in this procedure, this image here. Another thing that could happen after you do tips is if the patient's ascites resolves very quickly, and if they had a pre-existing umbilical hernia from their ascites, bowel can get trapped in the umbilical hernia, and the patient presents with nausea, vomiting, and exquisite pain in their belly. When you do a TIPS procedure on a patient with an umbilical hernia, you're going to say, look, right now you can reduce that hernia very easily. That umbilical hernia is soft. You can press it, and it'll go down to a flat abdomen. If after we do your TIPS, if that umbilical hernia becomes firm, painful, you can no longer reduce it, and you're getting nausea, vomiting, and abdominal pain, go to the emergency room immediately, because you have incarcerated bowel. And if you don't have an operation, that incarcerated bowel is going to get ischemic, necrose, and you're going to lose some of your intestine. Here's a really nice example of an incarcerated bowel loop after a TIPS was performed. And in this case, you can see the bowel loop protruding into the umbilical hernia. These veins draining this bowel loop become compressed. Venous pressure increases in that bowel loop, and if the pressure keeps increasing and is untreated, now the arterial inflow is going to be diminished, and now that bowel gets ischemic and necrotic if it's not treated emergently by a surgeon. Another complication is post-TIPS encephalopathy. Now that you're shunting all this portal venous system back to the heart, the patient could become encephalopathic. This is usually easily treated by the hepatologist by giving either lactulose or rifaximin. Lactulose is metabolized by gut bacteria. It's a disaccharide. It reduces absorbable neurotoxic ammonia production in the intestine. If that doesn't work, or you can use this rifaximin as an adjunct to lactulose. Rifaximin is a minimally absorbed antibiotic. It reduces the gut bacterial virulence, so the gut produces much less of the neurotoxic plasma endotoxin or lipopolysaccharide that causes the patient to have mental status changes. If this medical therapy is not working for the patient, the hepatologist will ask you to increase that portosystemic gradient. And you do this by using a reduction stent or a constraining tip stent. You could read about these in the literature. Basically, you want to narrow down the TIPS shunt. And in this case, they used a covered stent inside of the original stent. They have a nice hourglass configuration of this stent inside of the original stent to increase the gradient to make the patient less encephalopathic, or to get rid of their encephalopathy altogether. If you place that reduction stent or constraining stent and the patient is still profoundly encephalopathic, you really have no choice but to occlude the tips. You went through all this trouble to create the tips, and now you have to occlude it because the patient is upstairs in the room in a fetal position, unresponsive because they're profoundly encephalopathic. And now you're going to go inside the tips and occlude it, in this case by placing an Amplatz or occlusion device right here. This is published in 2007, a really nice example of how to occlude a stent. So in conclusion, I hope you learned a little bit from my presentation. You have a great responsibility, a great role, a great gift as an interventional radiologist to help these patients with portal venous hypertension. I showed you many ways you can do it through tips, through other types of shunts, balloon angioplasty, cover stent placement, many ways to help these patients with sinusoidal portal hypertension, pre-sinusoidal portal hypertension, or post-sinusoidal portal hypertension, a way to get them sort of back to living a normal life out there in society. So I hope this was helpful, and I'll be happy to answer any questions for you. Thank you.
Thank you, Professor, for a nice topic, nice talk. It was interesting talk. So,
You're welcome.
Anyone with question?
Yeah. Sure, you can ask questions or put them in your chat box if you'd like. I know in Tanzania, you performed your first tips, I guess about 6 weeks ago. I don't know if you've had any tips since then. Have you had any second or third tips? No.
So, hi, Dr. Paul, this is Ivan.
Ivan.
We are getting more and more cases for portal hypertension. When the way we are doing it is, some of them come with not typical indications of tips, and we've had to sit down and discuss about exhausting the prior treatment options like banding, endoscopic banding. Some of them come with only prior episodes of bleeding that probably were not managed well. So we get them to start medical therapy, banding, and then some others have come with ascites, and we've had a patient that we started on diuretics, and we went on increasing the doses, and for now the ascites is managed well with high dose diuretics, and we are following them up with their renal function. She's doing pretty fine. So it's also a learning curve to know how we can manage them better before we do the tips on them. We had this week a patient who came. He's I think a young adult. I don't remember the age, probably 20 or early 20s, and he reported that he has had episodes of hematemesis since he was 2 years old, and then these episodes in 2020 he had the first banding done on him, and since actually not 2020, I think like maybe some 5 years ago he had banding which was done, and since then he has never had bleeding episodes. So it was the first time we saw him. We just requested for a good imaging on him. He had ultrasound which reported that he had no signs of cirrhosis, he has no ascites, he has no splenomegaly. And so we were trying to imagine what would be the cause of these varices, because they reported on endoscopy when they went to do banding that he had esophageal varices. So we're still working up on this patient. We haven't had his CT yet, but we still think we have a lot to know. So I don't know if in this case we are thinking that we are going to, again, he also had severe thrombocytopenia. So we are thinking that you want to, first thing would be to investigate why he has these varices since and hematemesis since the age of 2, and then whether the problem is also splenic because he has thrombocytopenia. We still have a lot to figure out. So what would be your advice in that case?
Well, if this started from a young age, does he have congenital hepatic fibrosis maybe? Did you say a liver biopsy was done?
So no, our plan is to do biopsy. We requested for labs for him and imaging, cross-sectional imaging on him to have a better, clear picture of his disease.
And what is the platelet count?
It was below 50. It was, I think, 26.
Okay. You know, we perform TIPS all the time in patients who have low platelet counts, 40,000, 50,000. And it's very rare to have a bleeding complication from our TIPS procedure. And these are patients who oftentimes our needle goes out through the capsule of the liver during our TIPS attempts. So it's unusual to get a bleeding complication. You know, you have to follow all the rules and everything and try to be careful as possible. But when we started doing TIPS, we'd always give the patient platelets, but we really don't give the patient platelets anymore. But anyhow, with your patient, you know, who had this since he was a child, it sounds like he needs a good workup to find out exactly what's going on. It sounds like he needs a CT scan also to look to see maybe he does have some type of arterial portal shunt going on, something congenital. Or he just has congenital hepatic fibrosis. I don't know. But I'd be curious to find out what you find for that patient, and see how you're going to help that patient. I think you're going to find more and more patients coming to you for help. As I mentioned many times with you as a group in Tanzania, it's important to be visible up there on the floors, on the wards. Make sure you walk around the wards and talk to your colleagues, be present at their conferences, you know, with internal medicine doctors, surgeons, all the other doctors who deal with patients with portal hypertension, because they don't know what you're capable of doing. You have to tell them, you have to show them. And I can tell you that surgeons, they don't like putting surgical shunts in these patients with portal hypertension. They're long cases. They have a high mortality rate, up to 50% chance of dying during those operations. They are more than happy to have you put a TIPS or some other type of shunt in their patients, because TIPS these days, with current techniques, the mortality rate from a TIPS procedure is less than 5%. So I hope you get to do more and more cases at your hospital. And they're fun to do. They're interesting to do.
Yeah. So I have we have another case. It's a patient, mid-30s, that we have been working with. He was a referral from hematology clinic, and he came with severe thrombocytopenia, splenomegaly. He has features of cirrhosis, and he has no background of hepatitis, and he had severe thrombocytopenia. He has not had any episodes of hematemesis or upper GI bleeding. And he has very severe collaterals. He doesn't have any features of varices. The first treatment we gave him was splenic artery embolization, partial splenic artery embolization. His splenic count went, his platelet count went up a little bit. And then after some months, they went down, they dropped again. And he has now a platelet count of 9. Looking back to his control CT scan, it seems like we really under-embolized him, and he has like probably 80% of his splenic volume still normal and not embolized. So we thought about a repeat procedure to do a splenic artery embolization on him again. And so I'm mentioning this case because we talked about platelet transfusion before procedure, especially in this case. He has platelets of 9. So we discussed about this and we thought that maybe he needs platelet transfusion before we can do another splenic embo on him. What would be your comment on that case?
How did you embolize the spleen?
So I wasn't there, but the way we usually do it, we use PVAs and we do an angiogram at the main splenic artery. We choose the branches of the splenic artery. Usually choose the inferior branches. We target to embolize at least 50 to 70% of the splenic volume. So we have mostly done around 60 to 70% of the splenic volume. For him, I don't know what happened really. His splenic volume was really, we actually probably embolized like 20, if not less than 20% of the splenic volume. Yeah, we can't hear you, probably muted.
Sorry, what did you use to embolize the spleen, with coils or particles, or what?
We usually use PVAs, PVA.
Okay, so that's a really good question that you brought up, because when a doctor asks you to embolize for hypersplenism, and you go through the process of embolizing, and then their platelet count doesn't respond, or responds for a while, then drops down to 9,000 in this case, the doctors aren't going to be very happy with you for doing your procedure, because it really didn't help the patient. When you look back at the original description of embolizing for hypersplenism, what they say to do there is to get into the main splenic artery, way distal in the splenic artery, just before the splenic hilum, and start embolizing. Shower the spleen with particles until there is a noticeable reduction in the splenic arterial flow. Okay, and we use large particles. That's what I do. I use large particles. And then what you're doing is you're going to end up ablating probably 80% of the splenic tissue. You're going to have an island of tissue left in the central part of the spleen that's still viable, which you'd like to preserve, but the rest of the spleen will be dead. And that's your goal, to kill off most of the spleen. You want to keep that platelet count high, 100,000 or higher, for many, many months and years to come, okay? Now, in your case, the good thing about your case is you did not coil embolize or use an Amplatzer plug to embolize the main splenic artery. That's the biggest mistake that anyone could make, okay? And you did not do that. You used particles, you partially embolized the spleen. What's nice in your case is you could just bring that patient back and repeat what you did, put the catheter way out there in the distal hilum, and just shower that spleen with more particles, okay? And you're going to do that until the flow is reduced more than what you saw reduced initially. And that comes with practice, to know, well, how much flow do you want to maintain at the end of your embolization. But the nice thing about your case is you've not burned any bridges. You can still bring that patient back to particle embolize them, and that's what I think you should do. You want to infarct more of the spleen.
What about in terms of platelets transfusion in his case that he has 9,000?
Yeah. Well, what was the platelet count when you first embolized that patient?
It was 11.
Okay, it's not much higher than 9. And I'm assuming that you did not have any complication from your femoral artery access, right?
No, we didn't.
So you just have to be careful, make sure that you access that femoral artery below the inguinal ligament. So if you have a bleeding complication from that artery, you can compress it. Do you use vascular occlusion devices at your hospital? Vascular access occluders?
Yeah, for these patients with splenic embo, whenever we have them, we try to use vascular. There's one patient, I don't remember if it's this one, that we use the radial access on.
Okay, so you want to use a vascular occluder. I would personally use something called a per-close device, which is a suture-mediated closure device, but you can use other devices like Angioseal or a Minx device to help ensure that your artery does not bleed, your accessed artery doesn't bleed after the device, your femoral artery. You got away with it when the patient's platelet count was 11,000. I think you're going to get away with it now the patient's 9,000. It really does not help in a patient with a huge spleen to transfuse platelets because their spleen just gobbles all those platelets up. It sequesters all those platelets. So it's not going to help. But I think you should bring that patient back and re-embolize them.
Okay. So we have one question here from Dr. Latifa. When the tip is blocked and the patient gets relief, can the occlusion be removed in the future, or it is permanent?
It's permanent.
Okay.
Yeah, if you remove that plug, you have the risk of sending a lot of clot up to the lung. That patient has a massive pulmonary embolus. That's if you can even get to the plug. You probably can't get to the plug because you're blocked by clot. You can't get to the plug because thrombus is in the way. So no, once you decide to occlude off a tip, it's occluded permanently. You can't pull the plug out. If for some reason you want to put another tips in that patient in the future, you can put a parallel tips in, maybe using that same hepatic vein, maybe using a left hepatic vein for the second tips. But pretty much your referring doctor and yourself, you have sort of made the decision that this patient is profoundly encephalopathic from the tips. Nothing's working. You reduce the tips diameter, you use lactulose, you use rifaximin. The patient's compliant with their medical therapy, still nothing's working. You're just going to occlude the tips. And the problem is that the patient's back to their original problem, which is variceal bleeding or ascites formation.
Okay. Thank you, Professor, for your answer. So I think we can end here the session. Thank you very much.
Yeah, you're welcome. It was great talking to you guys.